Okay, let's unpack this. Have you ever truly paused to think about the incredible, often invisible work your lungs do? Every second, every day. It's this constant, almost effortless act of breathing that truly sustains us. Today, we're taking a deep dive into your respiratory system, really getting into it from the, microscopic wonders of how we exchange gases to understanding common ailments, the tools we use to assess lung health, and even, well, critical emergencies. Our mission here is to quickly make you well-informed about this complex and vital world, pulling out the most important nuggets of knowledge from our sources.
It's truly fascinating, isn't it, how interconnected every single part of our respiratory system is, and just how much there is to learn about keeping it healthy. We'll explore the system's core functions, how they naturally change over time, and importantly, what happens when things go wrong, offering insights that hopefully stick with you.
Right, and at the very heart of this incredible system are these tiny, remarkable structures. The
Alveoli.
Exactly, alveoli. You have hundreds of millions of them, something like 290 million.
That's the number, yeah. And this is where the magic really happens.
The vital exchange, right? Oxygen in, carbon dioxide out. Keeps every cell in your body going.
Precisely. But building on that, what's crucial to understand is that our respiratory system, well, like every other part of us, naturally experiences changes with aging. It's not static.
Okay.
As the years pass, that delicate alveolar surface area, the place where gas exchange occurs, it can decrease somewhat.
So less surface area for the work.
Right. And the lungs lose some of their elasticity, maybe like an old rubber band. It just doesn't snap back as quickly. And our ability to clear airways effectively, through coughing, that can diminish too.
Okay.
Airways also tend to close a bit earlier during breathing, and the overall efficiency of that oxygen and carbon dioxide exchange, well, it drops a bit.
Wow, okay, so several things happening there.
Yeah, and you also see things like muscle weakening, slackening vocal cords, even increased vascular resistance within the lungs. All of this contributes to a higher risk for hypoxia.
Hypoxia. It's essentially a lack of adequate oxygen reaching your tissues, right?
Exactly.
So what does this all mean for you listening? It means our lungs don't stay the same. They evolve. And understanding these natural shifts isn't just, medical trivia. It's a powerful tool for proactive health. Helps you support your body as it ages, maybe stay ahead of potential issues.
Couldn't agree more. Understanding is key.
So when we talk about understanding our respiratory system, getting a read on it, a thorough assessment is absolutely fundamental. And it always begins with history, gathering that vital information first.
Right. History is foundational.
This includes things like your smoking habits, and not just if you smoke, but how much and for how long. That pack years calculation.
Yeah, packs per day times years smoked. Crucial number.
And any childhood or adult illnesses, vaccinations, past surgeries or hospitalizations, even exposure to lung diseases or certain jobs.
That's a great foundation. And beyond that core medical history, what are some of the other critical cues we look for? Things that might signal a respiratory concern.
Good question.
We also delve into personal and family data, any genetic risks, for instance. We explore drug use, both prescribed and illicit. Allergies are important too, travel history, where you've lived. And for veterans, their deployment locations can be really relevant.
Okay.
Then we zero in on current health problems, like a persistent cough, or sputum noting its color, amount, hemoptysis that's coughing up blood, which is always concerning, chest pain, and dyspnea.
Which is simply shortness of breath, right? Feeling like you can't get enough air.
Exactly. Dyspnea.
Okay, so once we have that history, we move to the physical assessment. And for the lungs, well, what can our ears tell us?
A lot, actually. We listen for the normal sounds of breathing, bronchial, bronchovesicular, vesicular sound, different sounds in different areas. But what often really grabs our attention are the adventitious sounds, the abnormal ones.
Like crackles.
Yeah, crackles, which can sound like faint puffing or hair rubbing together. Wheeze is that classic whistling sound, often with asthma or COPD. Rhonchus, which is a lower-pitched rattling sound, sometimes cleared with a cough. And a pleural friction rub, which sounds a bit like creaking leather, indicates inflammation of the lung lining.
Okay. So listening is key.
Absolutely.
Huh?
But beyond what's audible, non-invasive diagnostic tools give us even more invaluable insights.
Like pulse oximetry, that little clip on the finger.
Exactly. Pulse oximetry measures the oxygen saturation in your blood. Ideally, we like to see 95–100% for most people. Though, importantly, we often adjust that expectation for individuals with chronic lung diseases. Their baseline might be lower.
Or in capnography.
Capnography measures the amount of carbon dioxide in your exhaled breath. Gives us a quick snapshot of how effectively you're ventilating, moving air. Then there are pulmonary function tests, or PFTs.
The breathing tests, right, where you blow into a machine.
Those are the ones. They assess your overall lung capacity, how quickly air moves in and out. Really important for diagnosing conditions like COPD or asthma. And exercise testing, too. Crucial for understanding how your lungs perform under physical stress.
But sometimes you need to get a closer look, right? A deeper, more invasive assessment.
Yes, sometimes non-invasive tests aren't enough. We might need invasive diagnostic assessments. These include procedures like endoscopy using a small scope to look inside. Bronchoscopy looks at the airways, laryngoscopy at the voice box, mediastinoscopy at the area between the lungs.
Okay.
There's also thoracentesis, where a needle is used to carefully remove fluid from the pleural space, that space around the lungs, and lung biopsy, where small tissue samples are taken for examination.
And with any of these invasive procedures, I imagine post-procedure care is critical.
Absolutely vital. Close monitoring is key to catch any potential complications early. For instance, after a lung biopsy, we'd assess vital signs and breath sounds regularly, maybe every 4 hours for the first 24 hours. We monitor closely for any respiratory distress, reports reduced or absent breath sounds immediately, and check for any signs of bleeding, like hemoptysis.
And after an endoscopy.
Similar vigilance. Check respiratory status frequently, perhaps every 15 minutes for the first couple of hours, until the patient is fully stable. Safety first, always.
Okay, so knowing all this, how our lungs work, how they age, how we assess them, what's one of the most impactful things you can do for proactive lung health?
That's a great question. A huge part of it is simply minimizing your exposure to irritants.
Irritants, like what?
Things in your home environment, dust, mold, certain cleaning products, things at your occupation, chemical fumes, dusts, or just general environmental pollutants, reducing exposure wherever possible.
Makes sense.
And building on that. What's truly, well, just astonishing, is the profound impact of smoking.
Still the biggest one, right?
By far. Including the newer forms, water pipes, vaping, e-cigarettes. The evidence is clear. Smoking cessation, quitting smoking, and actively limiting exposure to secondhand and even third-hand smoke. It's paramount for lung health. It's the single most effective thing for many people.
And for those ready to quit, are there supports?
Oh, absolutely. There are many effective medications available now. Nicotine replacement therapies like patches, gums, lozenges, they help manage withdrawal, and prescription options too, like bupropion or varenicline, which work differently in the brain to reduce cravings.
Good to know there are options.
Definitely.
And remember, knowledge really is power here, especially, I think, for older patients. Understanding how aging naturally affects respiratory health is so vital for maintaining their overall physiological integrity, their quality of life.
Couldn't agree more. Empowering patients with that knowledge is key.
Okay, let's shift gears a bit. Moving to the upper respiratory tract, we encounter common issues like epistaxis.
Nosebleeds.
Right, nosebleeds. While many are minor, just annoying, some can actually escalate into serious emergencies.
That's true. Persistent nosebleeds might need more intervention, like cauterization, sealing the vessel, or sometimes nasal packing to apply pressure.
But here's a really critical point our sources highlighted. Bleeding from the back of the nose, posterior nasal bleeding, that's different.
That is considered an emergency. Needs immediate medical attention. Can be much harder to control and potentially compromise the airway.
So for those situations, careful assessment is key, right? Checking for respiratory distress, making sure the person can tolerate any packing if it's used.
Absolutely. Interventions often include things like humidification to keep things moist, maybe supplemental oxygen, bed rest, sometimes antibiotics to prevent infection, and pain medications.
Okay, that's a good example of how something seemingly simple can become serious. What about another common challenge in the upper respiratory area, one that really impacts overall health?
This leads us nicely into obstructive sleep apnea, or OSA, a condition where your breathing repeatedly stops and starts while you're asleep.
Right, very common.
Extremely common and often underdiagnosed. Clinically, what might you notice? Maybe excessive daytime sleepiness, despite a full night in bed. Insomnia. Morning headaches are a big one. Sometimes personality changes, irritability, and of course, snoring, often loud, disruptive snoring. Longer term, it can lead to systemic hypertension, high blood pressure in the lungs called pulmonary hypertension, and even cor pulmonale.
Which is that type of heart failure linked specifically to lung conditions.
Exactly. Diagnosis usually involves an overnight sleep study, a polysonogram. And thankfully, at-home sleep study options are becoming much more available now, making diagnosis easier.
And treatment.
It ranges. Non-surgical approaches are usually tried first. Things like position-fixing devices to keep you off your back, non-invasive positive pressure ventilation, or NPPV, often called BiPAP, and the most common is CPAP, continuous positive airway pressure, using a mask to keep the airway open. If those don't work, there are surgical options too, like implanted stimulators for the nerve controlling the tongue, sometimes a tracheostomy in severe cases, or procedures to remove excess tissue in the throat, like a UPP.
Okay, so from common issues like nosebleeds and sleep apnea, let's now look at something incredibly serious. Head and neck cancers. This includes laryngeal cancer, which affects the voice box, the
That's a
larynx.
very serious area.
The crucial thing to remember here, though, is that these cancers are often curable when they're treated early. Our sources indicate about 80% are slow-growing squamous cell carcinomas.
Early detection is absolutely key.
So what increases the risk? Risk factors for laryngeal cancer include inhaled irritants. Tobacco smoke is major, but also other pollutants. Alcohol consumption, especially combined with smoking. Vocal straining, chronic poor oral hygiene, a family predisposition. It's also more common in men, and long-term GERD, acid reflux, might play a role.
And what cues should people watch for? What are the warning signs?
Persistent hoarseness is a big one, lasting more than 2 weeks. Pain or burning sensation in the throat when swallowing. Feeling a lump in the neck.
Enlarged cervical lymph nodes, persistent unilateral ear pain, pain just in one ear, shortness of breath, foul breath that doesn't go away, and unexplained weight loss. Any of those warrant checking out, definitely. And treatment options.
They vary depending on the stage and location. It could involve surgery, maybe removing just part of the larynx, supraglottic or partial laryngectomy, or sometimes a total laryngectomy. Laser surgery is also used, and radiation therapy, sometimes with chemotherapy.
And let's connect that to the bigger picture. A total laryngectomy, where the entire voice box is removed, is a profound life-altering change.
Huge impact.
Huge. It means no natural speech, at least initially, and the creation of a permanent stoma, an opening in the neck for breathing. This significantly impacts a person's appearance, their body image, and requires learning completely new, alternate communication methods.
So preoperative teaching must be incredibly important.
Absolutely vital. Patients need to understand before surgery about the loss of voice, the permanent stoma, likely needing a feeding tube initially, the change in appearance, and exploring communication options early on. Postoperative care focuses on things like keeping the head of the bed elevated, maintaining a clear airway through suctioning if needed, ensuring adequate humidification for the stoma, and getting speech therapy involved very early.
And long-term, at home.
Home care teaching is extensive. It covers stoma care, keeping it clean, using a shield over it, proper suctioning technique if needed, wearing a medic alert bracelet. Crucial precautions like avoiding swimming unless using special devices, being careful when showering, avoiding aerosols, sprays, increasing liquid intake to keep secretions thin, infection prevention, and having working smoke detectors is extra important.
Okay, a lot to manage there. Let's shift focus now down to the lower lungs and chronic conditions. Let's unpack chronic obstructive pulmonary disease, or COPD.
Right, COPD. A major one. It's really an umbrella term that encompasses both emphysema and chronic bronchitis.
And the primary risk factor is?
Still cigarette smoking. Overwhelmingly the primary cause. But passive smoking, recurrent respiratory infections, certain occupational exposures, air pollution, and even some genetic abnormalities like alpha-1 antitrypsin deficiency also play a role.
Okay, so break down the two main types. Chronic bronchitis.
With chronic bronchitis, the main issue is chronic airway inflammation. You get increased mucus production, that persistent smoker's cough. The airways narrow, respiratory drive can actually decrease over time, and bronchospasm tightening of the airways is common. Leads to hypoventilation.
And emphysema.
Emphysema involves damage to the lung tissue itself, specifically the elastic tissue in the airways and the alveoli, those tiny air sacs. This leads to air trapping. Air gets in, but struggles to get out, causing the lungs to overinflate over time. That's where you often see that characteristic barrel chest appearance. The damage affects the bronchioles, the alveoli, even the tiny capillary beds around them, ultimately resulting in hypoxia, low oxygen levels.
And the complications of COPD can be pretty severe, right?
They can be. Hypoxemia, low oxygen in the blood, and related acidosis. Frequent respiratory infections are a huge problem. Cardiac failure is a major complication, especially that right-sided heart failure we mentioned, cor pulmonale, due to the strain on the heart from the lungs. And cardiac dysrhythmias, irregular heartbeats, are also common.
So what are the key symptoms or physical signs you might notice if someone has COPD? What cues do we look for in an assessment?
Clinically, you'll often see dyspnea, shortness of breath, especially with exertion initially, but later even at rest. A chronic cough, often productive with sputum, a history of recurrent respiratory infections. Exposure to particulate matter, like smoke or dust, is key history. Physically, patients often adopt that forward-bending, orthopneic, or tripod posture, leaning forward with hands on knees to help breathe.
Using extra muscles?
Exactly.
Yeah.
Accessory muscle use in the neck and shoulders. An increased respiratory rate, that barrel chest we talked about. Listening to the lungs, you might hear wheezes or crackles, or sometimes breath sounds might be quite diminished, especially with emphysema.
And when it comes to managing COPD, what's the focus? What interventions help?
Management really aims to improve quality of life, reduce symptoms, and prevent exacerbations, those flare-ups. Interventions include teaching specialized breathing techniques, like pursed lip breathing, proper positioning to ease breathing, effective coughing strategies to clear mucus. Oxygen therapy is often prescribed based on oxygen saturation levels.
And medications.
Drug therapy is crucial. Bronchodilators are key inhaled medications like albuterol or terbutaline to open airways quickly, and longer-acting ones too. Methylxanthines like theophylline are sometimes used. Corticosteroids, often inhaled but sometimes oral or IV, like solumedrol during flare-ups to reduce inflammation. Mucolytics like acetylcysteine to thin mucus. Expectorants like guaifenesin to help cough it up. Sometimes antitussives like codeine if the cough is excessive and non-productive.
Wow, quite an arsenal of medications.
It often requires a combination. Plus, exercise conditioning is really important. Pulmonary rehab programs can make a big difference, suctioning if needed. And hydration, encouraging fluid intake, maybe around 2 liters a day, helps keep mucus thin.
Okay. Now, what's fascinating here, as you mentioned earlier, is how external factors can profoundly impact lung health, leading to occupational pulmonary diseases.
Yes, this is a significant area. These conditions are typically caused by long-term exposure to specific occupational or environmental hazards, fumes, dusts, vapors, gases, even bacterial or fungal antigens or allergens. And their effects are often significantly worsened by concurrent cigarette smoke exposure.
So prevention is really key here.
Absolutely paramount. This involves using specialized respirators designed for the specific hazard and ensuring workplaces have adequate ventilation systems. Engineering controls are best.
Can you give some examples?
Sure. Classic examples include coal workers' pneumoconiosis, often called black lung, from inhaling coal dust, and asbestosis, caused by inhaling asbestos fibers, which can lead to scarring and increased cancer risk. There are many others tied to specific industries and exposures.
Right. And then, of course, another major threat to the lower respiratory system is lung cancer. Again, an area where awareness of risks and early symptoms can genuinely be life-saving.
Critically important.
The main risk factors. Are we seeing a pattern here?
We are. Cigarette smoking is far and away the leading cause, but secondhand and even third-hand smoke exposure contributes significantly. Inhaled pollutants like asbestos, radon, and others. And there's also a family predisposition component for some lung cancers.
And the clinical manifestations, the cues, what should raise concern?
Early signs can be subtle and nonspecific, unfortunately. Things like a persistent cough that changes or worsens, hoarseness, vague chest pain or discomfort, shortness of breath, wheezing, maybe recurrent respiratory infections like bronchitis or pneumonia. General symptoms like fatigue or loss of appetite can occur too, but the late symptoms are particularly concerning.
Such as?
Hemoptysis, coughing up blood, clubbing of the fingers and toes, significant fatigue or weakness, dysphagia, difficulty swallowing if the tumor presses on the esophagus. These often indicate more advanced disease.
And management, what are the approaches?
Management depends heavily on the type of lung cancer, the stage, and the patient's overall health. Surgical resection removing the tumor is often the goal for early-stage non-small cell lung cancer. This could be a pneumonectomy, whole lung, lobectomy, a lobe, segmentectomy, or a wedge resection, small piece. Radiation therapy and chemotherapy are also mainstays, used alone, together, or in combination with surgery. Newer targeted therapies and immunotherapies are also making a big impact.
For those undergoing thoracic surgery, like a lobectomy, what kind of pre-op teaching is important?
A good pre-op prep is crucial. Smoking cessation well before surgery is ideal. Teaching breathing exercises, like using an incentive spirometer to practice beforehand. Explaining what to expect post-op, like having chest tubes, possibly needing a ventilator temporarily, and emphasizing pain management strategies. Managing expectations is key.
And post-op care, what are the priorities?
Post-op care is intensive. Frequent assessment of vital signs, oxygen saturation, SpO2, breath sounds, and sometimes arterial blood gases, ABGs. Promoting pulmonary hygiene, deep breathing, coughing, turning is critical to prevent complications like pneumonia or atelectasis. Keeping the head of the bed elevated, usually 30–40 degrees. If there are chest tubes, careful assessment of the drainage system is needed. Reporting drainage greater than about 70 millimeters per hour could indicate excessive bleeding. And there are specific considerations, for instance, after a pneumonectomy, usually no chest tube on that side, specific positioning guidelines, and watching carefully for signs of mediastinal shift or tension pneumothorax on the remaining side.
Right. Okay, let's move into infectious respiratory problems. Our lungs are constantly exposed to potential invaders. Let's start with common upper respiratory infections, URIs.
The common cold and its cousins, yes. While usually minor for healthy adults, URIs can be more serious for certain groups.
Who is at higher risk?
Infants and young children, the elderly, people who are chronically ill or immunosuppressed, those who are malnourished or dehydrated, people with a decreased level of consciousness. Also, individuals with allergies, smokers, people who are immobile, and unfortunately, patients who are hospitalized are at higher risk for various URIs.
And examples, beyond the common cold.
Things like sinusitis inflammation of the sinuses, which might require antibiotics like amoxicillin, Bactrim, or cephalosporins if it's bacterial and persistent. Seasonal and pandemic influenza, the flu. The annual vaccine is so important here, especially for high-risk groups. We always assess for egg allergies before giving the flu shot. And of course, COVID-19. Caused by a coronavirus, spread mainly by droplets, but also aerosols generated during certain medical procedures, its global impact has been immense.
Okay, so those are upper respiratory, but this raises an important question. What happens when those infections move deeper, down into the lungs?
When infections get into the lung tissue itself, we often encounter pneumonia. This is essentially an excess of fluid in the lungs resulting from an inflammatory process.
And that inflammation, what triggers it?
Usually infectious organisms, bacteria, viruses, fungi, but can also be triggered by inhaling irritants like chemical fumes or aspiration of stomach contents. This inflammation causes fluid and debris to fill the alveoli, which leads to reduced gas exchange. That's the core problem.
And how is pneumonia classified? I've heard different terms.
Right. It's often classified by where it's acquired, which helps guide treatment because different bugs are common in different settings. There's community-acquired pneumonia, CAP, picked up out in the community. Hospital-acquired pneumonia, HAP, developing 48 hours or more after hospital admission. And ventilator-associated pneumonia, VAP, developing in patients on mechanical ventilation.
Okay. And what are the typical cues or symptoms of pneumonia?
They can vary, but often include flushed cheeks, maybe some anxiety, chest pain, often pleuritic, meaning it worsens with breathing, headache, chills, fever, cough, which might be productive or dry, tachycardia, a fast heart rate, dyspnea, shortness of breath, changes in sputum color or consistency. And listening to the lungs, you'll often hear altered breath sounds, like crackles or bronchial sounds where they shouldn't be. It's worth noting, especially in older adults, the symptoms can be more subtle, maybe just confusion or a low-grade fever.
And prevention. How can we prevent complications like atelectasis, that lung collapse?
Preventing atelectasis is key in preventing pneumonia, especially post-operatively or in immobile patients. Encouraging deep breathing, coughing, using incentive spirometers, early ambulation, getting people moving are all vital.
Treatment for pneumonia.
It depends heavily on the suspected cause. For a common bacterial CAP like strep pneumo, a second-generation cephalosporin might be used. For Legionnaire's disease, erythromycin. For AAP potentially caused by Pseudomonas, stronger antibiotics like aminoglycosides might be needed. And pneumonia in immunocompromised patients is a special challenge. Could be things like pneumocystis carinii pneumonia, PCP, often seen in HIV, or fungal infections requiring drugs like amphotericin B.
And you mentioned VAP, ventilator-associated pneumonia. Any specific management strategies there?
Yes, VAP prevention bundles are critical in ICUs. Key elements include keeping the head of the bed elevated 30–45 degrees, daily sedation vacations to assess readiness to wean off the ventilator, prophylaxis for deep vein thrombosis, DVT, and stress ulcers, meticulous oral care with antiseptics, sometimes using special endotracheal tubes that allow for continuous suctioning of secretions above the cuff, and of course, rigorous hand washing by all staff.
Okay, now here's a condition that requires serious vigilance globally, pulmonary tuberculosis or TB.
Yes, TB, a major public health concern worldwide. It's a highly communicable infectious disease caused by the bacterium Mycobacterium tuberculosis.
And how is it transmitted?
It's transmitted via aerosolization. Tiny airborne droplets containing the bacteria are expelled when an infected person coughs, sneezes, speaks, or sings, and then inhaled by someone else.
No, a crucial fact our sources highlighted. An infected person isn't necessarily contagious right away.
That's correct. You can have latent TB infection where the bacteria are dormant and you have no symptoms and can't spread it. An infected person is generally not contagious until they develop active TB disease, when symptoms occur. We also see secondary TB, which is a reactivation of latent TB, often occurring when a person's immune system becomes weakened, common in older adults, those with chronic diseases like diabetes or kidney failure, or people with HIV.
And who is considered high risk for contracting TB?
Certain groups face a higher risk. Homeless older adults, individuals with alcohol or drug use disorders, the elderly in general, people living in institutional settings like nursing homes or prisons, anyone who is immunosuppressed. Those with low socioeconomic status often have higher rates due to factors like malnutrition and crowded living conditions,
Yep.
and immigrants from countries where TB is highly prevalent.
Okay. And what would the symptoms, the clinical manifestations of active TB look like?
They can be insidious, starting slowly. Often a persistent low-grade fever, maybe chills. A cough is common. It may or may not be productive initially. Night sweats are a classic symptom. Fatigue, lethargy, unexplained weight loss. Later symptoms might include hemoptysis, coughing up blood, and increasing shortness of breath as the disease progresses.
How is TB diagnosed?
Diagnosis involves several steps. The Mantoux skin test, or PT test, is common. A tiny amount of purified protein derivative is injected intradermally under the skin. The site is then read 48 to 72 hours later. We measure the induration, the hardened, raised area, not just the redness. The size considered positive varies depending on the person's risk factors. For example, 10 millimeters is positive for most people, but 5 millimeter might be considered positive for someone with HIV.
Are there other tests besides the skin test?
Yes, blood tests called interferon gamma release assays, or IGRAs, are increasingly used. Examples are quantiferon TB Gold and T-spot TB. They measure the immune response to TB bacteria. A definitive diagnosis requires identifying the bacteria itself. This is usually done through sputum culture. We look for acid-fast bacilli, AFB, under the microscope, but culture confirmation can take several weeks, 1 to 4 typically. Chest x-rays are also important, often showing characteristic changes, especially in the upper lobes.
Treatment for active TB, I understand it's quite rigorous.
It is. Treatment involves combination drug therapy, usually with 4 drugs initially, commonly isoniazid, INH, rifampin, pyrazinamide, and ethambutol. This combination helps prevent drug resistance. Strict adherence to the medication regimen for many months, often 6 months or longer, is absolutely critical for a cure. A person is generally considered no longer infectious after about 2-3 months of effective treatment, usually confirmed by 3 consecutive negative sputum cultures.
And these drugs, do they have significant side effects to watch for?
They do, and monitoring is important. INH can cause peripheral neuritis, nerve tingling, or pain, especially in the hands and feet, and hepatotoxicity, liver damage. Vitamin B6 is often given with INH to prevent neuritis. Rifampin also carries a risk of hepatotoxicity. It famously causes body fluids like urine and tears to turn orange. Patients need to know this. It can also cause low blood pressure, increase the metabolism of many other medications, and discolor soft contact lenses. Ethambutol can cause optic neuritis, affecting vision, so regular eye exams are needed. Pyrazinamide can cause fever, rash, increased uric acid levels leading to gout, and photosensitivity.
Wow, okay. Lots to monitor there. Is there prophylactic treatment for people exposed or with latent TB?
Yes. For latent TB infection, prophylactic treatment, usually with INH taken once daily on an empty stomach for 6 to 12 months, often with vitamin B6, can prevent progression to active disease.
And what are the key nursing interventions when caring for someone with TB or managing TB control?
Nursing plays a huge role. Identifying close contacts of people with active TB for testing and potential treatment is crucial. Reporting positive PPD results or active cases to the local health department is mandatory. Ensuring medication adherence is vital, often through direct observation therapy or DOT, where a healthcare worker actually watches the patient take their medications. Educating patients is key. Take meds on an empty stomach if possible, or at night if nausea is bad. Avoid alcohol, especially with INH and rifampin, due to liver toxicity risk. For active pulmonary TB in healthcare settings, strict respiratory isolation in a negative pressure room is required until the patient is no longer infectious. And promoting effective home and self-care strategies is essential for long-term management.
Okay, that covers infections really well. Now let's turn to those critical situations. The acute emergencies where the respiratory system is under immediate threat. Scenarios where rapid intervention can literally be the difference between life and death.
Right. These are the high-stakes situations. And what's truly critical, or perhaps fascinating in a frightening way, is how quickly something like a pulmonary embolism, or PE, can develop. And it often originates somewhere else in the body entirely.
A PE, that's a clot in the lungs, right?
Essentially, yes. It's a collection of particulate matter, most often a blood clot. But it could also be a fatty deposit from a broken bone, or even an air bubble that enters the venous circulation and travels until it lodges in the pulmonary vessels, obstructing blood flow through the lungs. Most PEs actually develop from a deep vein thrombosis, or DVT, a blood clot in the deep veins, usually of the legs or pelvis.
And what puts someone at higher risk for developing a DVT or PE?
Several major risk factors. Prolonged immobility is a big one. Think post-surgery, long travel, bed rest, central venous catheters. Surgery within the last 3 months, especially major abdominal, pelvic, or orthopedic surgery. Pregnancy increases risk. Obesity, advanced age. A personal or family history of thromboembolism. And interestingly, COVID-19 infection has also emerged as a significant risk factor for blood clots, including PEs.
What are the classic warning signs, the cues for a PE? They can come on suddenly.
Very suddenly often. The most common cues are sudden onset shortness of breath, often unexplained and severe, extreme anxiety or a sense of impending doom, tachycardia, a heart rate typically over 100 beats per minute, and tachypnea, a respiratory rate usually over 20 breaths per minute. Chest pain, cough, or hemoptysis can also occur.
And nursing management, what's the immediate focus?
Immediate focus is on supporting oxygenation and circulation. Oxygen therapy is crucial, sometimes requiring high-flow oxygen or even mechanical ventilation if it's a massive PE. Ensuring adequate hydration with IV fluids. Anticoagulants are started immediately, usually with heparin initially, followed by warfarin or newer direct oral anticoagulants to prevent new clots from forming and existing ones from getting bigger. Monitoring closely for bleeding is essential, along with lab values like PTT for heparin and INR for warfarin. We assess respiratory and cardiac status frequently, maybe every 30 minutes initially, and managing pain and anxiety is also important.
Are there more invasive treatments for PE?
Yes, for large, life-threatening PEs, treatments like a pulmonary embolectomy, surgical removal of the clot might be considered, or thrombolytic therapy, clot-busting drugs. Sometimes an umbrella filter, an IVC filter, is placed in the large vein, returning blood to the heart to catch future clots before they can reach the lungs, especially if anticoagulation isn't possible.
Okay. Next up, in critical conditions, acute respiratory distress syndrome, or ARDS. This sounds serious just from the name.
It is very serious. ARDS isn't a specific disease itself, but rather a complex clinical syndrome, a pattern of severe lung injury and inflammation.
What happens in ARDS?
Basically, there's widespread damage to the delicate alveolar capillary membrane, the interface where gas exchange happens. This leads to increased permeability. Fluid leaks into the alveoli, causing pulmonary edema. You get severe ventilation perfusion, VQ mismatch, meaning parts of the lung are getting air but no blood flow, or blood flow but no air. Gas exchange becomes severely impaired. The inflammation also destroys the cells that produce surfactant, the substance that keeps alveoli from collapsing, leading to widespread alveolar collapse, atelectasis, and significantly decreased lung compliance. The lungs become very stiff and hard to ventilate.
What causes such severe lung injury?
ARDS can be caused by direct lung injury, things like aspiration of stomach contents, severe pulmonary infections like pneumonia or COVID-19, near drowning, major thoracic trauma, or inhaling toxic substances. Or it can result from an indirect injury, a systemic process that affects the lungs. Common causes include shock, septic, cardiogenic, hypovolemic, sepsis, severe hypothermia, DIC, disseminated intravascular coagulation, multiple blood transfusions, eclampsia in pregnancy, severe pancreatitis, or extensive burns.
And the symptoms.
The hallmark is the rapid onset of severe dyspnea and respiratory distress, usually within hours to days of the inciting event. Patients become profoundly hypoxemic, low PaO2 levels that don't improve significantly even with high concentrations of supplemental oxygen. Cardiac output can decrease. A chest X-ray typically shows diffuse bilateral infiltrates, often described as a whiteout.
How is ARDS managed? It sounds incredibly challenging.
Management is primarily supportive, aiming to treat the underlying cause while supporting lung function and preventing further injury. Intensive oxygen administration is key, often requiring mechanical ventilation with specific strategies, like using low tidal volumes and positive end expiratory pressure, PPP, to keep alveoli open. Sometimes, continuous positive airway pressure, CPAP, can be used if ventilation isn't needed yet. In the most severe cases, extracorporeal membrane oxygenation, or ECMO, essentially an artificial lung outside the body, might be necessary. Avoiding fluid volume overload is critical. Meticulous pulmonary hygiene, turning, and repositioning are important, including placing the patient in the prone position, lying on their stomach, which can significantly improve oxygenation in many aortes patients. Corticosteroids, antibiotics if infection is present, bronchodilators, and NSAIDs might be used. And nutritional support is vital.
Okay, and connecting this to the bigger picture, you mentioned mechanical ventilation. In these critical states, like severe ARDS or other types of respiratory failure, this becomes absolutely essential, right?
Absolutely essential. Mechanical ventilation takes over the work of breathing, supporting gas exchange when the patient's lungs are unable to do so adequately on their own.
What are the main indications for using a ventilator?
There are several common indications. During surgical procedures requiring general anesthesia, for patients with a decreased level of consciousness who can't protect their airway, post-operatively sometimes. Certain neuromuscular diseases that cause respiratory muscle weakness, like Guillain-Barré or myasthenia gravis, spinal cord injury or severe head injury, drug overdoses that suppress breathing, and of course, acute respiratory failure from conditions like ARDS, severe pneumonia, COPD exacerbations, or multiple trauma and shock.
Are there risks or complications associated with mechanical ventilation?
Yes, while life-saving, it's not without risks. Complications can include aspiration, atelectasis, or infections like VAP, which we discussed. Oxygen toxicity can occur if high levels of oxygen, greater than 50%, are used for prolonged periods, typically over 48 hours. Barotrauma or volutrauma, tissue damage from excessive pressure or volume, and ventilation can sometimes decrease cardiac output due to increased pressure within the chest.
So what's the focus of nursing management for a patient on a ventilator?
The mantra is always, assess the patient first, then the equipment. Continuous, vigilant assessment is key. This includes frequent respiratory assessment, breath sounds, work of breathing, oxygen saturation, and vital sign monitoring. Assessing cardiovascular status and fluid balance, and rigorously assessing the ventilator equipment itself, checking the settings against the orders, ensuring alarms are set appropriately and functioning, monitoring airway pressures and volumes.
What about getting someone off the ventilator?
That's the goal, of course. The process is called weaning, transitioning the patient from ventilatory dependence back to spontaneous breathing. This often involves conducting spontaneous breathing trials, SBTs, where the ventilator support is reduced or temporarily stopped to see if the patient can breathe adequately on their own. Once the patient meets criteria and successfully passes an SBT, extubation, or the removal of the endotracheal tube, can occur. But even after extubation, close monitoring is critical for signs of respiratory distress, like stridor, a high-pitched airway noise, which might indicate swelling and the potential need for reintubation.
Okay. And finally, let's touch on trauma. Direct injuries to the chest can obviously have a major impact on the respiratory system.
Definitely. Chest trauma can be broadly categorized as blunt or penetrating.
Let's start with blunt chest trauma, like from a car accident or a fall.
Exactly. Common injuries include sternal and rib fractures. Fractures of the upper ribs, 1 to 3, are concerning because they can potentially lacerate the subclavian blood vessels underneath. Fractures of the lower ribs, 5 to 9, carrying a risk of lacerating the liver or spleen. Management for simple rib fractures usually focuses on pain control, absolutely essential, so the patient can breathe deeply and cough effectively, along with breathing exercises and splinting the chest when coughing.
What about flail chest? That sounds more severe.
It is. Flail chest occurs when multiple adjacent ribs are fractured in 2 or more places, creating a segment of the chest wall that's detached from the rest. This leads to paradoxical respirations. The flail segment moves inward during inspiration when the rest of the chest moves out, and outward during expiration. This severely impairs ventilation. Management often involves aggressive pulmonary hygiene, encouraging turning, coughing, deep breathing, TCDB, suctioning as needed, and often requires intubation and mechanical ventilation to stabilize the chest wall internally. Pulmonary contusion bruising of the lung tissue itself often accompanies flail chest and further complicates breathing.
Okay, and penetrating chest trauma, like a stab wound or gunshot.
Right. Penetrating injuries can cause several critical problems. A hemothorax is when blood collects in the pleural space. A pneumothorax is when air collects in the pleural space, causing the lung to collapse. Pneumothoraxes can be spontaneous, happening without obvious injury, often in tall, thin young men or people with underlying lung disease. Traumatic open, from an injury that creates an opening in the chest wall. Or a tension pneumothorax.
What are the general signs of any pneumothorax?
Cues typically include sudden chest pain, shortness of breath, tachypnea, rapid breathing. Listening to the chest, you'll likely hear reduced or completely absent breath sounds on the affected side. You might also see asymmetric lung expansion on one side doesn't rise as much as the other.
And in severe cases?
In severe cases, particularly a tension pneumothorax, You might see tracheal deviation. The windpipe shifts away from the midline, away from the injured side, due to the pressure buildup.
Tension pneumothorax sounds particularly dangerous.
It's a life-threatening emergency. Air enters the pleural space but can't escape, building up pressure that collapses the lung, shifts the heart and great vessels, mediastinal shift, and severely compromises breathing and circulation. Signs include extreme respiratory distress, cyanosis, bluish skin, distended neck veins, severe tachycardia, and hemodynamic instability, quickly leading to respiratory failure if not treated immediately with needle decompression, followed by a chest tube.
You mentioned chest tubes. What's their role?
Chest tubes are inserted into the pleural space to remove air in pneumothorax, or fluid blood in hemothorax or pleural effusion. Their purpose is to allow the collapsed lung to re-expand and to restore the normal negative pressure within the pleural space, which is essential for breathing. Nursing care involves managing the chest tube drainage system, monitoring the amount and type of drainage again. Reporting drainage greater than about 70 millioles per hour is often a critical threshold, assessing for air leaks and ensuring the system is functioning correctly.
Wow. We have really covered a huge amount of ground today. Everything from those millions of tiny alveoli doing their silent, vital work
The microscopic level.
to the profound ways our lungs change as we age. The many, many ways we assess respiratory health, from listening to complex diagnostics.
Right. The assessments and tools.
And how we approach and manage everything from, a simple nosebleed to serious conditions like COPD and lung cancer, and even those critical life-threatening emergencies like PE, ARDS, and major trauma.
It's a complex system with a wide range of challenges.
It really is. Hopefully, this deep dive gives you a fantastic shortcut to being genuinely well-informed about the incredible intricacies, the vulnerabilities, and also the resilience of your respiratory system.
And perhaps this raises an important final question for you to consider. Knowing the immense vulnerability, but also the incredible resilience of this system we rely on every single second. What one proactive step will you take, starting today perhaps, to safeguard your breath, for today and for your future?